I've got your slide practical ready. I have a normal slide for each of you. I have an abnormal slide for each table. I pulled out my practical from last year and I looked at the slide under the scope. It was horrible. I would not subject you to it. The colors were wrong. It was faded. I was having trouble telling what they were. So I can't very well give you something that is horrendous like that on your practical. So each table will have to share a slide, but I was able to find enough slides that are the same or close enough to the same. They have the same type of cells on them, similar counts. The one set has a little bit higher count, so it'll go a little faster. Then I have retic slides that I made fresh this morning. I'm still waiting for them to dry. I'll take a look at them and make sure they're reasonable before I hand them off to you. If not, I still got the specimens sitting there. I can zap up another dozen without too much ado.
Is the retic on the practical?
Yes, the retic is on the practical.
So if you did one yesterday, you can do another one today?
Yep. Yep. The practical is separate. Let's see, retic is on the practical. So 2 slides, one normal, one abnormal, and you'll recognize the abnormal pretty quick. One normal, one abnormal, and a retic. It's all including on your diff practical. You're gonna have 40 minutes to do it. That should be plenty of time to do 3 slides. Honestly, but probably about 15-20 minutes is all it should take. And experienced tech, you guys aren't experienced, so. But that's about all it should take. After that, I want you to kind of finish up on any of the diffs, have at least 5 off of that last tray that I gave you. If you've got time, I'll give you a CML to do. I'll see if I can find some ALL ones. Tuesday's gonna be fairly simple. Oh, and we have to do sickle dex today. It's not quite as hard as SED rates. So I think you guys will zip through that one pretty quick. Tuesday is gonna be a fairly light day in lab. Finish up anything that you haven't done. CML, AML, or ALL. And I don't know, I may have one other slide. I haven't decided whether I'm gonna give it to you guys or not. I'm gonna give it to a fellow tech tonight who is not super experienced at diffs and see how she does with it. In fact, she's probably done less diffs than you guys have. So if she does well with it, you're getting it. If she's totally flummoxed, I'm not gonna bother. I'll save it and do it as an in-class slide with the next class. It's a lymphoma, so it's kind of odd. Any questions? I guess we'll finish, what we're going to do next week is Tuesday we'll have a test, and there will be a picture test on Tuesday with it, and it won't be that one. It won't be that one. It will include not only single cell identification, but there's gonna be a couple that are disease state recognition. Believe me, if it will be, if it's sickle cell, it's gonna be the picture that's got the huge, massive sickle cells that you can't mistake for anything else. If it's iron deficiency anemia, it's gonna be micro and grossly hypo. CML is pretty self-explanatory, big blobs of immatures. CLL is pretty self-explanatory. B12 folate, what am I gonna see on B12 folates?
The hypersegmented, right?
Hypersegmented neutrophils, and what am I gonna see red cell wise? Polychromasia, poly, you should just, poly, then you don't sound like, what's the rest of it? Poly. Polychromasia, and somebody else, what else am I gonna see? Galloblastic anemias, which are maybe B12 folates. What kind of red cells am I gonna see?
Is that the microhypo?
The what? I heard 2 different answers come from over here.
Is it microhypo? Or is it normal? No, I don't know.
Macro.
Macro?
Yeah, there's only one left. No spherocytes. Macrocytic, oval macrocytes. Polychromatophilic oval macrocytes.
I might have to put this here.
No, that's fine.
It's easier to hear.
Okay, no problem. Okay, let's see, how far did we get?
Enzyme deficiency?
I believe this is where we were headed to? In case you can't tell, I'm going on like, I need to go home. Okay. Only 15 hours to go, I'll be fine. Enzyme deficiency, immune hemolytic. How about from current slide? All right. The immune hemolytic anemias, and we'll probably refer back to these a little bit when we hit immunology this fall. They basically fall into a couple of different categories. Many of these have to do with blood type, and as you'll find out from Barb next spring, there's more blood types than A, B, and O. There are Kell, Kidd, Duffy, Lewis, Lutheran. I don't know. That's all my brain can come up with right now. But there are other blood groups aside from just the ABO, and a lot of these immune hemolytic anemias are transfusion related, the ones that we see commonly. Warm autoimmune hemolytic anemia. Warm doesn't necessarily refer to the temperature in the body. It refers to the temperature at which the antibody we're looking at reacts. These warm autoimmune hemolytic anemias are going to react at Coombs phase. You won't need to remember that until Barb gets you. They're going to react at 37-degree Coombs, all right? They are more significant. The warm autos are much more significant. For one thing, if you have a warm autoimmune hemolytic anemia, there is no blood that's compatible. Period, end of sentence, it doesn't exist. You have an antibody to human blood. We actually have got a few residents who understand this now. Yay! It takes a while. The doctor will have to sign an emergency consent no matter what. They're not compatible with themselves, so they're not going to be compatible with anybody else. Okay. It is mediated by IgG, and that is important to remember, that the warm autoimmunes are IgG mediated. Many of them, most of them, are idiopathic. We don't know why you get it. We think you just do it to tick off blood bankers. I don't know. But you wind up with a mild to moderate hemolysis, and this is not good. You're going to have a positive DAT, which is a direct antiglobulin test. This is also known as a Coombs test. Again, I'll let Barb get more into that later. We have cold autoimmune hemolytic anemias. With these, you can find compatible blood. You just have to do all your testing in the warm. These are going to react at room temperature or below when we're talking about them for blood bank-wise. The other thing is, obviously, if you get cold, it's going to be worse on you. These are mediated by IgM, and you are going to need to know that. Which are mediated by IgG and which are mediated by IgM. Yes.
What's the difference
What do you mean?
in the IgG and the IgM?
They're two different immunoglobulins. They have a little bit different structure, a little bit different function. And again, it's one of those kind of cyclical descriptions. This fall, you'll learn more about that than you want to know. But IgM generally reacts at room temperature or below. It's the first responder in a reaction, in an immune response. Warm autos are IgG. IgG is our primary immunoglobulin that does most of the heavy lifting for us. Okay. Structure's a little bit different, and it tends to react more at 37. Yes.
You said warm hemolytic anemia is essentially an antibody against shifted blood. Is it the same with cold?
Yes. Yeah. The thing is with the warm, you can never get it compatible. The cold, if you just kind of test it when it's warm, you can get it to go away sometimes. Sometimes those colds are so strong that you can't get them to go away. Okay. But they're not significant. They don't cause the in vivo hemolysis, the intravascular in vivo hemolysis that the warms do. Drug-induced hemolytic anemia is just that. Certain drugs given to patients are going to cause them to have a hemolytic anemia. We already talked about one of them. What is it? Well, let me rephrase that. What enzyme deficiency is susceptible to a drug-induced hemolytic anemia? G6PD, right? And it's especially vincristine, which is against ALL. And what's the other one that triggers our G6PD problem? Fava beans. I don't know why, just does. I've never had a fava bean. Someday I want to have one, just out of curiosity. All right. HDN stands for hemolytic disease of the newborn. In this case, what we wind up with, you know that you can have your ABO type, so your A, your B, your AB, or your O. We also have positive and negative. That's your RH type. The anti-D, which is what makes us Rh positive, is an extremely strong stimulator for antibody production, which is why you have to make sure that you give Rh negative people Rh negative blood. Okay? And again, Barb will get much more into that later. What HDN is that the mother gets sensitized to D. She makes anti-D, an antibody to the D antigen. In the first baby, it's not a problem. But subsequent children, IgG, which is a warm reacting antibody, can cross the placenta. So this anti-D antibody crosses the placenta and attacks the infant's red cells. How well do you think an infant develops without blood? Or with increased bilirubin and all of the stuff that comes along with it? Basically what happens the first pregnancy, again, no problem. Once she becomes sensitized, if she gets pregnant with another Rh positive baby, it becomes progressively worse. This is something that actually we don't see as much of anymore, especially in the developing world, because we came up with something called RhoGAM. Okay, so, and again, we will let Miss Barb talk mostly about that. But essentially what RhoGAM is we give your body a shot and fool it into thinking it already made the antibodies. So now you don't have to make them. So mom is not sensitized. This artificial antibody just gets processed out of your body. It doesn't last. It doesn't hang around forever. And so therefore you don't get sensitized, and it's safe for you to have other Rh positive babies. This can lead to severe birth defects, exceptional mental retardation, physical problems, or in utero death when it gets severe enough. Mostly we see this in really old ladies now. It used to be just old ladies. Now it's really old ladies. Because once RhoGAM came on the market, this became very uncommon. Okay. It can still happen, and it can happen with antigens other than D. But again, I'll let Barb get more into that. But HDN is where the mom's body attacks the baby. oops, PCH is also known as Donald Landsteiner. That's the doctors who found what was causing this. It's called paroxysmal cold hemoglobinuria. We had another paroxysmal one. What did we have? It wasn't cold. What was it?
The coolies?
No, that's beta thalassemia. PNH, nocturnal, paroxysmal nocturnal hemoglobinuria. In this paroxysmal cold hemoglobinuria, this is an autoimmune related one. Okay. And what happens in this is massive intravascular hemolysis after exposure to cold. These people, if they get really cold, their finger, it's frostbite from the inside. Their fingers will turn black, the tip of their nose, the edge of their ears. Okay. Clinical finding, backache and leg pain. Okay. The backache a lot of times is from the fact that your kidneys are really overworked trying to get this hemoglobin out of there. Abdominal cramping and headache. The treatment, quite seriously, stay warm. Okay. They can give steroids for a lot of these immune mediated type things, but frankly with this one, keep them warm. You might want to move to, away from here. Move someplace where it doesn't really get extremely cold. It is an IgM. This is a form of cold immune related anemia. I imagine it depends on the patient, but usually below what normal room temperature, down in the 40s, 50s.
Can it have like severe, like if somebody really got frostbite, would it like cause them possibly lose fingers or something like that?
Yeah, it can result in necrosis, but usually you don't get to the necrotic stage because if you're that cold, you get
Yeah, no,
dead
I figured.
from the hemolysis. But yes, it can cause necrotic tissue to the point of amputation.
Okay.
But it is IgM. Transfusion reactions. This is what happens when you don't give somebody the right blood. It occurs within minutes or hours, an immediate transfusion reaction. This one's generally due to an ABO incompatibility. And giving ABO incompatible blood is simply clerical and unexcusable. There is no excuse for a patient getting the wrong blood type. None. Either the phlebotomist didn't pay attention and drew the wrong patient. That happens. The blood bank tech typed the wrong patient. The nurse hung the wrong unit. But in a proper system where you draw the blood, you test the blood, you get the blood, you give the blood, as long as all of the steps are followed, this should not happen. Basically, if you don't know the patient's blood type or in doubt, you give O negative. And even if we've had the patient in the past, until we have a specimen, this admission, we give O negative. You could have seen them 50 billion times. Oh, she comes in once a week for transfusion. She's an A. If I don't have a specimen from her today, she's getting O. You'd really have to. We've had, there have been problems. Severe intravascular hemolysis is severe as in it pops all of your blood cells. You just transfused in 300 milliliters of packed red cells, and your body destroys every last one of them. Your haptoglobin cannot keep up. It can shut down your kidneys, it can shut down your liver, it can shut down your brain, and that shuts down you. It is a particularly horrible way to die. Okay. Delayed transfusion reactions, on the other hand, are not something we can necessarily prevent. It may occur days after transfusion. It's generally due to blood groups other than ABO. Okay. The immediate transfusion reactions, I need to kind of back up a little bit. There's no reason for giving the wrong ABO type. I have seen some immediate, or actually read in the literature, immediate transfusion reactions where a patient had a antibody other than the ABO types, and blood that was incompatible was given to them. The screen, after a while, that antibody titer, it gets low enough that you can't find it. And when you give them blood that is positive for that antigen, it comes back with a vengeance. The JKA and JKB are notorious for that. So if you don't have a history on the patient, it's possible they formed an antibody in the past. It went down below detectable limits, but then when you gave them a unit of blood that was positive for it, the titer skyrockets back up, and they do have this reaction. That one, there's no wrongdoing there. It's a bad thing that happens. It just happens, and you've done all your testing, you've done what you can. It's the ABO incompatibility that is pretty much somebody had to screw up somewhere for ABO incompatibility. The delayed hemolytic transfusion reactions, hemolysis may or may not be as severe. You may have a lot, you may have a little. Basically what this is somebody makes an antibody to something besides the A, the B, or the A or the B. Yes?
Did you say sometime this week maybe that it's possible for your blood type to change under certain circumstances?
The only time your blood type can change is if you have had a bone marrow transplant. And you will blow every blood banker's mind. We had a patient drawn for the 4th time, and the oncologist called down and goes, "You all do know she had a bone marrow transplant, right?" No one told us that. She had been, I don't even remember what the blood types were. Let's say she'd been an O for the last 20 years, and suddenly she was a B. I mean, we're drawing this lady over and over and over and over, figuring we had to screw up somehow. We're going to give her O anyway. In fact, we wound up giving her O just because we didn't feel comfortable giving her B. But her blood type changed. But the only way that can happen is, number one, you're not the same person. We've seen that a lot. Yes, we've seen that more than once. We've actually, that's why you only get O. Because what happens sometimes, insurance, we had a lady in ICU for several days, if not weeks, before we found out she wasn't who she said she was. She was very, very ill, and her friend, out of the kindness of her heart, not fraud, not trying to be evil, but just trying to help her friend out, let her have her insurance card. So she was in as Jane Smith. Well, we had a long history of blood banking stuff on Jane Smith. Well, it was really, Lisa Robbins or something. And we did her blood type again, and she was the wrong person, and it turns out that's what had happened. So it is not uncommon for people to share. Now, in this particular case, it was not to be fraudulent. In other cases, there's people who sell their insurance card, use of their insurance card. It does happen. So somebody comes in as somebody else. Or we have one, she's been in under 4 different names. She is the same person, but she has been in under 4 different names. And not just like, well, she's, she got married, so her last name changed, or she hyphenated it and then decided not to hyphenate it and hyphenated a couple of other things, Not that kind of name change, but, Mary Smith, Lisa Robbins, Johanna something or other, Mary Garcia. I mean, she has multiple identities, and she keeps coming in. I haven't quite figured out how they haven't done something about it, but she's been in under 4 different identities. The problem we have, she has an antibody. So if it was just an ABO thing, it's no big hairy deal. We do your ABO type, whatever your name is today, and we're going to be right. But she has an antibody. And so if she comes in with the wrong name and we give her the wrong blood because we don't know she has that antibody, we could have some major problems with her.
Is she foreign?
What?
Is she foreign?
No.
So it's not like a illegal.
How does she? Don't she have to give her social security numbers and stuff? How is she
You
getting
got
away
me!
with
Yeah,
it?
I don't know how she's getting away with it. We don't know.
That's crazy.
And this isn't
I
a,
feel like I sell my life away every time I go to the doctor.
what's that?
I feel like I sell my life away, like giving your insurance card.
Yeah.
Social security card.
That's why I said, I don't know how these people do it. I would be a nervous wreck.
Mhm.
Yeah, this is one of the problems we had when we got our new computer system, the particular system that we have. Everything's done by your account number. That's the one they give a damn about, is what your account number is, what we're billing this time. And they didn't worry that if the medical record number changed. Well, the medical record number, you get one medical record number, and that associates everything you've had. Your account number changes every time you come in. They couldn't understand why Blood Bank was in such a tizzy that they were giving these people new medical record numbers. Well, because if I don't know what her history is, I could kill her. That's kind of important. So they were just like, well, I don't know what you're all so worried about the M number for, because in the lab, we like to see what their history was. If they've got a history of myeloproliferative disorder and we get their diff in, we're going to go, oh, damn, this again. Okay. If they come in and don't know that they have a history, you're going to go, oh, God, okay, we got to get this done. We got to get this reported to get this patient treated. So it does make a difference to us, that consistent number. It drives us insane. Oh, by the way, he's got 2 M numbers. That's not acceptable. We can't do that. What do you do if he's got a new M number? So, all right, patient has an antibody. And, of course, that's usually when our problem is. Patient has an antibody. He came in with the number 1, 2, 3. Now he's 4, 5, 6. Well, let's say I find out. Legally, I don't have to honor the antibodies from 1, 2, 3. And if I don't know it, I may miss the antibodies from 1, 2, 3. And if his screen is negative on 4, 5, 6, because we honor an antibody. Once you have it, you get you get a negative for that antibody for the rest of your existence. So, yeah, and okay. All right, physical causes. This is where the red cells are not. There's nothing wrong with the red cells. They just getting smushed. Something is smashing your red cells. The first one is microangiopathic hemolytic anemia. Basically, the red cells are fragmented by fibrin deposits. You all remember from coag, I know you do. What happens at the end of your coag process is you get this fibrin strands, right? Well, if the red cells go through them, imagine them going through like piano wire or like an egg slicer. As they go through, those fibrin strands shred them, which is why part of our DIC workup is looking for schistocytes. Because if you have DIC or these little bitty aggregate clumps all through your system, it's going to be shredding your red cells. We also find this in TTP, sepsis, malignant HTN, which is malignant hypertension, i.e. really bad high blood pressure. Okay. And HUS, which is hemolytic, you can read it, hemolytic uremic syndrome. Okay. This is when you have an increase in uric acid. It tends to coat your cells and leads to it. Severe intravascular hemolytic anemia, microthrombi in circulation. We're going to see a decrease in platelets because they're going to get used up. Now, that's in uncompensated, right? What happens when we get to compensated? Platelet count increases, right? Smile and nod. I know you know that. And we are going to see schistocytes. Macrovascular. The most common cause of this basically is a defective heart valve. Okay? When our heart is beating, what happens? The valve opens, the blood goes through, the valve closes. The valve opens, the blood goes through, the valve closes. When you've got a defective heart valve, the valve opens, gotcha, and it smushes them. Literally, physically just smashes the little suckers. Okay?
So
You're
is it
good.
spasm?
Huh?
Is it spasm?
No, it's just the heart valve is defective. Either it's not closing correctly, or it's closing partially, or it's not closing at the right rate. But whatever it is, the heart valve itself is not closing properly. Like I said, it's more like whack-a-mole. The thing we see here, a very mild anemia with very few schistocytes, although I have seen it get really, really bad. They put in a new valve that worked worse. Treatment is going to be surgery. Go in and replace the heart valve. Okay. This is one of those cases where, is the anemia bad enough? Which is worse, a little bit of anemia or open heart surgery? Kind of depends on your patient's condition, obviously. You know, if your patient's relatively healthy except for the heart defect, you're going to go in, you're going to fix it, everything's going to be happy, hunky-dory. If your patient's not stable, you might be better off trying to just manage the anemia with nutritional support and perhaps even transfusion if you need to. Okay. As I've mentioned before, it used to be transfusion was just an accepted treatment. Now, if you have to transfuse a patient repeatedly, it's considered poor management of the patient. And insurance companies get very upset with you. Marching or athletic hemoglobinuria. This is really a thing, guys. The forceful impact of your feet. Every time your foot hits the ground, you bust a couple of red cells. We are not talking about I went and you know, went out for my okay, not my daily jog, but somebody went out for their run. Okay, you went out for your run for a couple of miles and you came back. We're talking, this happens more in marathon runners, people who run dozens of miles a day. The treatment for this, seriously, get good shoes. You know, that's honestly the treatment for this. It actually was first noted, believe it or not, in Roman legions. They would march for 20 or 30 miles a day, and they did start to show signs of yellowing of the sclera, a little bit of excess bilirubin stuff. They showed signs of this because, you know, they were marching 20 or 30. Can you imagine walking 20 or 30 miles a day, carrying full armor? You know, that's adding an extra 75 to 100 pounds to your body, and you're marching. Yes?
People who walk cross country, things like that, when they don't carry a rucksack or anything like that, is it going to be an issue without the extra weight?
I couldn't tell you how much impact it takes, but it takes a lot. Like I said, this isn't our, oh, I did my 20 minutes on the treadmill today. You know, no, this is pretty much hardcore training. Infections that can cause problems. Malaria. This is still a very big deal in the world. It still kills millions of people every single year. There is no cure for it particularly. Basically, you can give quinine, which is preventative. The biggest thing is keep the Anopheles mosquitoes away, which is why 2 years ago, I think it was, the NBA sponsored a huge drive called Nets for Nets. And they collected money and stuff and provided literally hundreds of thousands of mosquito nets to people in Africa and Asia, South America. Basically, where do you find malaria? Find the equator, Tropic of Capricorn, Tropic of Cancer, that band right around the middle. Okay. They have found a couple of cases they found a couple mosquitoes that had it in Florida. We immediately had, I went to Florida, I think I have malaria. No, you don't. Okay. What? Yeah, well, it will move north and south, I'm sure. Yeah.
I don't know anything about malaria. I wasn't here the day you talked about it, so this is probably stupid. But is it contagious? Like, if you don't get bit by the mosquito?
No. The only ways you can get it by being bit by the mosquito. The female mosquito lands on a person and sucks their blood. The plasmodium goes into their system. Then when they go bite the next person, the plasmodium transfers out to the other person.
So it's a blood-to-blood transfer, and it usually has to go through the mosquito. You could get it, I suppose, from a blood transfusion, which is why people who've been to malarial areas are not allowed to donate blood.
And if you were pregnant?
If you were
Then
pregnant,
get
you
it.
could pass it to your infant, yes. Yes. But as far as I know, I don't remember if this is, you know what, you guys are going to do parasitology next spring. Somebody get back to me and let me know if the mosquito is a necessary part of the life cycle. There are some parasites that even if I pass it directly from me to you, it wouldn't survive because it needs that vector. There's some part of its life cycle that only takes place in the vector. And I don't remember if Plasmodium is one of those. Yeah. Oh.
So anytime you get bit by any mosquitoes, you get somebody else's plasma?
Yep. Okay, you know when you do a finger stick, that before it starts to bleed kind of redness, that much. I mean, you're talking a microliter or less. Yeah. So are you going to catch it? No.
I was just curious.
Yeah. Yeah, pretty much. Yeah.
So you say that there's no cure for Plasmodium, malaria, whatever it is, but they have shots for people who are going to malaria country.
That's quinine, it's prevention.
So it will actually prevent it, but it
It'll
won't
prevent you
cure
from
it.
getting it, yeah. And quinine
What
is,
it exactly doing?
huh?
What exactly is it doing?
There's something about that chemical that keeps the plasmodium from being able to infect the red cells. It was one that, you know, modern medicine didn't come up with it. It was found because in the Amazon rainforest, certain natives ate the bark off of a tree and they didn't get malaria. Well, that was quinine. That there's some chemical in that particular bark, and I'm sure they synthesize it now, but there was some chemical in the bark that protected them from malaria. Findings, we're going to have a febrile, we're going to find a febrile illness accompanied by chills and body aches, and it's cyclical. As the plasmodium has its log phase of reproduction and kind of has a lot of babies at one time, your fever goes up. As it kind of settles back down to the lag phase where it's not actively reproducing quite so much, it's going to go down. It's going to come up, it's going to go down. For the most part, once you've got it under control, once you've got the patient who's gotten rid of the malaria, it doesn't come back. However, there are a couple of kinds. They can lay dormant in your bone marrow for decades. Vietnam veterans, there were a lot of them who went to Vietnam and came back and were fine while they were young and healthy. When they got older and their immune system wasn't quite as up to snuff, they actually had reoccurrences of malaria. So it is something that can be recurring for a lifetime. So but we can get them through it with support. Okay.
Without treatment.
Barb's out here. Okay, we're gonna let her come in. Hang on.
What does febrile mean?
Febrile.
Okay. All right. Babesia. Babesia is another intracellular parasite. Looks very much like malaria. It is, however, not spread by malarial parasites, and it's found up in the northeast. It's known as Nantucket fever because it was first found in Nantucket. It is an intracellular parasite spread by the deer tick. And the last infection that we talk about that causes a severe hemolytic anemias are Bartonella, and that's known as arroyo fever. And that's all you need to know about that one. That's enough. The last piece we have that can cause hemolytic anemias, I'm sorry guys, there are a couple of different bacteria the most common one being Clostridium perfringens. And again, we'll let Jean get more into this kind of stuff. It's an anaerobic gram-positive organism that produces a toxin that causes severe intravascular hemolysis. It's related to botulism, which is Clostridium botulinum, okay, which is what they use for Botox. The same stuff that causes lockjaw is what they use to inject into people. Some people are nuts. Okay. But Clostridium perfringens can produce a toxin, and so it's not just the bacterial infection, but the toxin that it produces causes hemolysis. Yes?
Okay, so I have a resident that, due to their cerebral palsy, they freeze. They get shots of Botox to loosen them up. Why is that something that will also cause lockjaw?
I have no idea. Have no idea. That's way beyond my realm of expertise. Drug-induced hemolytic anemias, again, these are ones that certain people, you give them a medication and it just for some reason causes a severe hemolytic anemia. Antibiotics are prone to doing this, probably more than any other class of drugs. Venom, the brown recluse spider, any of your hemotoxic snakes, which include rattlesnakes, cobras, and pit vipers. Any of the other, the one-steppers and the two-steppers, the black mamba and stuff, those are not causing hemolytic anemia. Those are neurotoxins, and that's why they're deadly faster. Okay. So rattlesnake bites, cobra bites, pit viper, if you can get the antiserum fast enough, you'll survive. The other ones, not so much. That's hemolytic anemias in a nutshell. There's a lot more information in your book, a lot more detail on a lot of this stuff. Like I said, I'm just trying to give you the bird's eye view of this stuff, break it down to as simple as I can make it, that's going to give you enough information to get on with. Okay.
Are these the last two study guides?
What?
Are these the last two study guides?
The other stuff we're going to go over on Tuesday, probably half hour, 45 minutes. We're going to go over the automated differential stuff, but I am not going to be testing you on it. I have to go back and I'll revise the final exam so that stuff is not on there. That doesn't mean you don't have to pay attention, because this is stuff you're going to be using when you get out into the clinical site, which is why I'm not so worried about testing you over it. And honestly, if you want to impress your clinical instructors, pay attention, because most of them don't know about how to do this kind of stuff. So, but it's got some really good information, really quick, really easy to look at, and yeah, that's kind of cool. Did you have a question, Helen?
I just wanted to know what category of like disease states Lyme disease fell under.
Lyme's disease is an induced autoimmune disease, and we will talk a lot about that when we hit serology. Okay. But yeah, it is not a hemolytic. Okay. All right. Miss Barb is going to talk to you and give you your first chemistry assignment. Aren't you excited? You just all look so thrilled. Okay. I know, you can barely contain yourselves. So after she's done, I want you to go ahead and get started on your practical. In fact, as while she's talking, I'll get the papers printed out. Does anyone have any questions about what I want you doing today? Talk to Barb. Do your practical.
Which is a retake, a normal, and an abnormal.
Mm-hmm.
And then for our last week sheet, the little sheet that you had us do the CML and the AMLs.
The ATL slide.
When we did the count all together, you told us to put it on
Right.
the sheet.
Yeah, I need we're going to turn everything in on Tuesday. I want all of it. Get all of your stuff. Anything you haven't turned into me, turn it into me on Tuesday.
So between this week and last week, we went 5 diffs.
Yeah.
The regular diffs,
Yeah.
and then
How do we use the diff for our, sorry.
What's that?
for our practical?
The what?
We can use the disc that we're doing for our practical as one of the 5.
No. No. The practical's separate. It's its very own thing. It's its very own thing.
And
Same
so
with the
other
two we
than,
did
other
together
than
in
the
class.
practical, what slides do we need? Other than the 5 normal tests, nothing?
Not normal, the slightly abnormals. And then
We need 5 of the slightly abnormal?
5 of the slightly abnormal. And then 1
Was last
CML.
week- Was last week slightly abnormal?
Mm-hmm,
The
yeah.
week 6.
The week 6 ones, yeah.
Were they?
They had bands, they had metas and milos, they had ATLs. Or they should have.
No.
I mean, I probably had some ATLs, but I didn't see any metas and minos on there.
Those are the ones I told you. If you look at
Because
what
we
there
only
was.
had 1 day last week. In lab.
Okay, I'm trying to remember which slides I gave you last week. The ones you've been doing this week have metas, milos,
Right.
ATLs. Yeah, okay.
Uh-huh.
Last week, whatever you got done last week, you got done. That's it.
Okay.
Yeah,
so-
you're done with last week.
Okay,
Yeah,
so
that's
we
the day we
need-
had the snow day.
We need 5 abnormal.
5 of
Every
the slightly
week.
abnormals for this week.
Okay.
Right. And then you'll do a CML and an ALL slide, and you'll either do them today or you'll do them on Tuesday. Then I'll give you time on Tuesday to do a practice practical if you want to. Then Wednesday, we'll do test review, and if you would rather do practice practical that day, you can do that. And then Thursday, we're going to split into 2 groups. Half of you will do the practical first, half of you will do the exam first, and you're going to swap. Okay? Then after that, we're going to Cutters, which means Jean is going to buy us pizza. Jean always buys good pizza. Yes.
I want to ask another question. The practical, all the 3 practicals that we did, the slide practical, the CBC, and
RBC.
will that all be on the final practical?
The
Or-
final practical, if you look in your syllabus, there's a rubric
Okay.
that tells you not only what's on the final practical, but how I grade it, exactly what I'm looking for.
What about the KC slides? That was on the 6.
We're going to review those on on Tuesday.
Okay.
On Sunday.
I'll see.
I haven't been to bed yet, so I am extremely, extremely tired. I had about 3 hours the night before last, and then last night, by the time I got home, got my homework done, I went to bed about 5:15, and I got up at 6:30. So I'm just a little bit on the
Oh, it's not so bad.
uggy side.
You're on autopilot.
I'm on autopilot. Yeah, it's a good thing I know hemolytic anemias very well because I'm certainly not thinking very straight. But I know my stuff, so at least on this one. Some of the others I'm just winging it. Yeah, I just fake it good, so. Sometimes that's all it takes. Now, the first year I taught this, I was like, hey, you only got to be 1 chapter ahead of the students. And there were times I wasn't.